All right. Well, first of all, thank you to the McKaig Institute and the Wood Forum for inviting me to give a talk on an area that I'm very interested in. And I also like to congratulate both the McKaig Institute and Wood Forum to transition this to an online whereby we can reach a lot more individuals who are interested. I'll give a quick shout out on that note. Actually, I invited my parents and my family to join this as well. They hear me talking about this all the time over dinners, and they never really got to see any presentation I've given. So this is a great way to reach out to more people. So I'm going to jump into this here, and feel free to post any questions, and we can definitely get to it at the end. So what I'm going to be doing here is I'm going to talk about technology and medicine in general. Talk about hip replacements in general, and then jump into the anterior approach. Some of the research that I've done, it's ongoing, and then talk about another exciting area that I've been devoting my time into, which is digital navigation, and then we'll summarize it up again. So to jump into it, medicine practice today is virtually unrecognizable from the turn of the last century, and technology will continue to transform medicine. It's very exciting in that manner. But with new technology, it has a potential of improving quality, efficiency, and safety. But we have to be careful because it can be sensitive and can introduce new risks and dangers. But we always need to try to strive to use technology to help advance our techniques. So total hip replacement or arthroplasty. It's one of the most effective and safe orthopedic procedures, and it's just exponentially increasing the number of procedures that we perform because of the success of the hip replacement. And both Canada and US data show that. What is a hip replacement? So in general terms, we take an arthritic hip, we basically cut out the arthritic part and we replace it with a prosthesis. And it is the single most successful surgery of all disciplines in surgery to increase a patient's quality of life. And we've heard John mention that. So what am I talking about here? Basically, I'm talking about how we get to the hip joint, because regardless of how we get to the hip joint, hip replacement surgery is just a good operation. And so the majority of hip replacement surgery worldwide is performed through something called a posterior approach, where we go through the back and to approach the hip joint to replace it. The other common way of performing it, and it's most common in Canada, is the anterior lateral approach, whereby we, again, approach the hip joint. And in both of these approaches, we have to take off muscles and tendons in order to get into the hip joint to expose it. And once we can expose it, we can replace it. But with some of the approaches, dislocation of a hip joint is one of our most feared complications and situations that can happen. It can happen up to 5% in hip replacements, especially highest with the posterior approach. There are studies showing that if reattachment of some of those tendons and muscles that we have taken off are reattached, that we can reduce the risk of dislocating. But regardless, dislocation is still the highest with the posterior approach. When we look at the other approach, which is the anterior lateral approach, it reduces the risk of dislocating, but you can have a persistent limp, which can continue on even up to 3 months. And that's because of some of the muscles that we take off and again, have to reattach at the end. So it's a balance between dislocating and limping that we always have to play. And because of the fear of dislocating, here's what we teach patients beforehand. So for the first 3 months, don't lay on the operative side, use a raised toilet seat, use a chair cushion, and walking aids for up to 3 months and sometimes longer if necessary. And then for life, don't bend past 90 degrees, cross your legs or pillow between the legs when you're sleeping. And all these precautions are just to try to avoid the hip from dislocating. But our patients are changing. As time is going on and with the success of hip replacements, patients are getting younger. And while they're getting younger, their demands are changing. They're asking us for shorter recovery, quicker return to work, fewer post-surgical limitations, and more durability. And us as surgeons need to figure out how we can meet these demands. So what is the anterior hip replacements? The anterior approach is essentially another way of getting to the hip joint through the front, which is an internervous and intermuscular plane. What that means is we're able to get to that hip joint without disrupting a lot of those muscles and tendons. It's not a new approach. In fact, it's been described in the 1940s, but this technique is only starting to gain popularity now, and that's because of standardized instruments and teaching programs. So what is it? So we go through the front between two of these muscles called the tensor fascia and the rectus muscle, which gives us good exposure of the hip joint. And what it effectively allows us to do, it allows us to maintain all the dynamic stabilizers of that hip joint. Now, what that means for patients, it means an increased stability to the hip joint, a shorter inpatient stay in hospital, reduced risk or the lowest risk of dislocating at somewhere between 0.2 and 0.4% in the literature, faster functional recovery, no restrictions after surgery, and less pain. So there's a picture of one of my patients who's 6 weeks after having her hip replacement performed. But the benefits also go beyond the patient themselves. So from the anesthesia point of view, during the case, they have full access to the patients because they're lying on their back. And so if something were to go wrong, they have full access to patients to provide the necessary care. From the surgeon's perspective, we can use X-ray during the case, and I'll come back to this a little bit later, which allows immediate feedback. So I know exactly where all the implants are. I know exactly what has happened during the procedure, and I can make adjustments if necessary. From the nursing and the rehab perspective, they're extremely excited when they have a patient who has a hip replacement through an anterior approach because they have less pain. Patients are more independent and able to move around a lot easier after surgery. And the hospital administrators also are quite excited about it because there's less bed congestion. In other words, we're able to have patients be discharged home safely, quicker. So this is the same slide that I showed you beforehand with the restrictions after surgery, but with the anterior approach, it's a lot different. In other words, all these restrictions which we have normally asked patients to do, with the anterior approach, essentially there are none. And so patients are able to be up and walking and are more comfortable. And so after surgery, as long as your surgeon is comfortable with it, there's no restrictions post-op. And here's a patient of mine. So, and by the way, all the videos that you see on this are from patients of mine who have agreed to allow me to show these videos. So here's a patient who's had her right hip performed in just less than 20 hours. So this is just less than a day, and she's up and walking around already on it and feeling quite comfortable. So the anterior hip replacement, there are some restrictions on it. So in my practice, 95 to 98% of any patient who presents to me with hip arthritis requiring a replacement would be a candidate for it. But there are some limitations behind it. And some of those limitations include morbid obesity, congenital deformities, if it's a revision operation, or we have to do the surgery again, or if there's fractures. Specifically periprosthetic fractures, fractures around a previous hip replacement. So why is it only starting to gain popularity now? It's because it is technically a lot more difficult in the operating room. So it does take a bit longer to perform the procedure. It is physically a lot more demanding for the surgeon and surgical team. There is a large learning curve associated with learning the procedure. It is a bit unfamiliar if you have a surgeon who hasn't done it before and the team hasn't done it before. It's just a different way of looking at the hip joint. There are new instrumentation which need to be taught and used to, and it can be disorienting at times. So here's one of those instruments. This is an orthopedic table. It's used for the anterior approach. It's not necessary, you don't have to use it for the anterior approach, but certainly makes the surgery a lot easier. So here's a patient of mine. She's 3 days out from having, she's home. And this is the same patient who's 17 days post-op on her canoe. Less than 6 weeks post-op, she's going for a hike. 12 weeks post-op cross-country skiing. And she's so excited by it, she sends images of herself to our office, just how excited that she is. And here's another patient of mine. She asked me to show this video because she was so excited that in less than 6 weeks, she's able to wear her high heels. So I told her I would definitely show this video whenever I can on my presentations. And so research is an area of interest of mine and something that I always enjoy performing. And so some of the research that I'll talk to you about is some of the safety and the cost effectiveness of the anterior hip replacement. So I'll start off with a retrospective matched cohort study. And essentially what this is we took patients who underwent primary uncomplicated hip replacements through the anterior, posterior, and lateral approaches. We excluded those patients who had both hips done at the same time, or hip resurfacings, or infections, or revisions. And basically, we took these patients and we looked at approximately 115 anterior hip replacement and matched them to 230 posterior approach and 230 lateral approach patients. We matched using age, gender, number of medical comorbidities, and BMI. So what did we find? So this was essentially the conclusion. There was no statistical significant difference at 30 days for readmissions of patients and no significant medical events. So we showed that it's actually safe. In fact, when we looked at it closer, there were significantly fewer mechanical complications. And what this includes is dislocating. There is shorter length of stay in hospital. Patients were able to go home directly more often rather than having to go to a rehab hospital because they were more comfortable and be able to pass our physiotherapy requirements. Fewer blood transfusions. And the most interesting part was the patients were consuming less narcotics in hospital and they were reporting less pain in comparison to the other approaches. The average surgical time was longer with the anterior approach in comparison to the other two approaches. So we were quite excited about this and our preliminary data, and we began to increase the ability to perform this on various diagnoses. So we took this to the next step. We looked at patients who had hip fractures and said, well, can we apply this to hip fractures? And as per current care pathway, the average length of stay with a patient who has a hip fracture may not be Dr. Boyd, but it was between 9 and 14 days in hospital. And so we took the patients and we fixed a cohort of them who were able to get up and mobilize and are relatively a bit younger and performed it through the anterior approach. And we were excited to see that we're able to reduce the length of stay in hospital to approximately 2 days and 12 hours and 30 minutes to be exact. So this was remarkable. And then we took it to the next level. Here's a patient of mine who has both of his hips are extremely arthritic. And this is how he has to get into his truck because of how arthritic those hips are, in a very uncomfortable way. So what we did, we took these patients who in general had a length of stay, if you imagine 2 different surgeries being performed, they would have to be performed at 2 different time points. And so the minimal time between surgeries would be about 3 months. So a total time to recover about 6 months. So here's hips, and again, as we initially saw the X-ray with the hip being a ball in a socket, there was really no space left between this ball and the socket of both of these hips. So we took him to surgery, and I performed bilateral anterior hip replacements on him. So at the same setting, was able to replace both of these hips. And what was remarkable, so he's now 4 weeks after surgery. He likes to joke around a bit, so he started trying to make this video, and he said, oh, forget it, I don't need these canes, and started walking. So it's remarkable, at 4 weeks after having both of his hips replaced, it's completely changed his quality of life. Now, when we look at our actual data that we had collected afterwards, it's even more remarkable because patients were essentially comfortable. They were consuming minimal narcotics, even after having both their hips performed, and they were being discharged home quicker. So these patients were being discharged home the following day, versus if they were having 2 separate procedures performed, and the average length of stay is about 3 days on a standard hip replacement. We're looking at a difference between being discharged home the following day versus 6 days in hospital in total. So, of course, it makes sense that if patients are in hospital less, that we must be saving money to the healthcare system. So patients are being more happier. They're being able to perform a lot more and faster functional recovery. And then we want to look at the perspective of the healthcare system. In summary, I just jumped to the basic conclusion. What we're able to show is that even when we subdivided all of the cost, and we used a micro-costing technique whereby patients were, every dollars that the healthcare system had to spend while they were in hospital were calculated, we averaged saved approximately just under $2,000 per patient that had the anterior hip in comparison to the lateral and posterior approaches. Now, there's a second way of calculating that if you just look at length of stay and using an average number, but essentially if we use the micro-costing as the better approach, that we save just under $2,000 per patient per day. And what does that, per patient per procedure? Now, what does that mean? If you look at it from a broader scale, if we just do 200 patients, then we've saved just about $370,000. Um, So with the immense success of the anterior hip replacement, I then took it to the next level and said, well, if patients are more comfortable and they're able to be up and mobilizing quicker, why can't we do this at the same day? So in other words, allow patients to go home the same day after having their procedure performed, which is extremely relevant with the situation we're currently in with the pandemic, and patients don't want to be in hospital very long, which is understandable. And so for the last 3 years, I've been performing same day total hip replacements. And it's amazing to see how well patients do. In fact, some of the happiest patients are those patients who don't have to stay in hospital and go home the same day. So here's an example of that. So this is a patient who's 4 hours after having the replacement. And I apologize, this was a video, but it doesn't seem to be playing unless we can have the AV individuals play the video. Oh, there it is. Thank you. So this is only 4 hours after having his left hip replaced, and he's essentially walking past the physio, and he at 6 hours, he's good to go home. So as excited as we were, I began performing anterior hip replacements at the Peter Lougheed Center in 2015, and we were the first in Western Canada, and only the third site in Canada to perform it. And since then, there's been a slow and careful uptake. Excited to say that all 4 sites in Calgary right now are performing it with 3 orthopedic tables. We have approximately 8 surgeons in Calgary performing the anterior hip replacement, and we're likely the single largest city currently performing anterior hip replacements based on the number of surgeons performing it in a single city. With the data that we collected, we were able to publish our cost-saving, our micro-costing analysis in HIP International. If we looked at, again, the amount of money that we saved over the course of 5 years, we've saved well over $1 million already. And this is just exponentially increasing the more we perform the anterior hip replacements. And I've had the privilege of teaching surgeons across Canada and especially within Alberta as well. So I'm going to take this to a different thought process. It's something called digital navigation. And this is another exciting area of technology that I've been using for approximately 1.5 years, close to 2 years now, and exploring how this can help us even further with the anterior hip replacement. So with the anterior hip replacement, like I mentioned, you can use X-ray during the procedure in order to identify where these prostheses are being placed. And X-ray allows for immediate feedback so that all alterations can be made if necessary. With using the X-ray, we can use something called digital navigation software, which is essentially software that allows us to template digitally what we should be expecting during surgery. And then during the procedure, allow us to make necessary changes. It's non-invasive. It allows us to have better implant selection positioning and helps us achieve leg length and something called offset, which is where the hip is being placed more accurately. So how does it help me? It's basically, I like to call it as data-driven surgical decision-making. And again, just before surgery, I'm able to take the information in the X-rays and use the software to digitally template beforehand. And during the procedure, again, you can use a predictive trial analysis, whereby, in other words, a fancy way of saying that you can trial a hip and figure out exactly what's right for that patient, depending on what the deformity was beforehand. And it really helps us understand better how the hip is behaving. And so I'll just show that in a very difficult case of a 77-year-old female who previously had her hip replaced 15 years ago, had a difficult post-operative course, and so really did not want to undergo another replacement on her other side and tried to avoid it as much as possible. In fact, she had a dislocation after having the right hip performed and was in a brace for about 3 months. And eventually did well on the right side, but just did not want to undergo her left hip. But eventually got to a point where she just didn't have a choice anymore. She just could not bear to live the way she was. And if we look at these X-rays, it's pretty easy to tell. You get the right hip, the image on the left side where the prosthesis is placed. That would be that patient's right hip versus the left side. You can tell there, if you look at the ball in the socket, not only is there absolutely no space, but the ball doesn't even look like a ball anymore. It's basically flattened out completely. And so she's basically eroded away part of that ball or the femoral head just because of how the bone-on-bone arthritis just kept rubbing against each other. So this becomes a very difficult case in order to, technically as a surgeon, if I just draw a simple line at the bottom, we can see that this patient not only has a bad hip, but it's about 15 millimeters short, so a centimeter and a half short of that left leg because of the erosion of that hip joint. And so as a surgeon, I will always try to see if I can improve that and try to get it closer if possible. Sometimes it's not. So we take this digital navigation software and we be able to overlay implants beforehand to see what am I trying to achieve during surgery. During surgery, I'm able to use this digital navigation software to help place components and make sure that I have the right degrees of where I'm trying to aim for that implant to be placed for each patient. And sometimes it may be slightly different, but it allows me to make those adjustments. Once I'm able to do that, I can then trial and see if what I've achieved is what this patient hip will allow, and if I can make alterations on that. And if so, if I'm able to achieve that extra bit of leg length that I started off performing. And by using that software, sorry, let's go back a bit here. By using that software, I was able to achieve equal leg length for this patient and a stable hip joint. So it is remarkable, and it's a new way to really think about hip replacements, and it's quite exciting as well. And so exciting that this patient here of mine was jumping for joy and how happy he was with the hip joint. It's just about 6 weeks. Not that I recommend doing this, but he was extremely excited about it. So in summary, total hip replacement is one of the most effective and safe orthopedic procedures, regardless of how it's performed or regardless of which approach, to be honest. But the anterior approach is a way to help improve rapid recovery after surgery. Hip replacement surgery is the #1 surgery known to mankind to improve patients' quality of life. Despite the immense success of hip replacement, we continue to try to make it better, and digital navigation is just one area where we're currently looking into. Thanks.